really revolutionized things. NMOSD in its early years was almost a terminal diagnosis with a 5-year life expectancy of 68% and a high proportion of patients being blind or immobilized in a short period of time. These targeted antibodies, what we've learned is we're gaining a lot of understanding about the immune underpinnings of NMOSD, which then allows us to look at these therapies that target those mechanisms. And so we're seeing sort of a precision approach to NMOSD, and these agents are really amazing. So especially our complement focused agents, Eculizumab and Ravulizumab, show staggering results in terms of relapse prevention. On the downside, their cost is at times prohibitive. Eculizumab is given every 2 weeks through intravenous. And so Ravulizumab is given every 8 weeks through intravenous. And the treatment group in that trial had no events. So those agents are really revolutionizing this disease. We have our IL-6 targeting agents, which also show excellent results. And we have our B-cell targeting therapies, which, Rituximab's one we've used for years, and then Inebilizumab is a more recent addition with really good data. So in NMOSD, with more precision focus, we're changing outcomes. This is no longer a disease where once you've had that diagnosis, you're doomed, which it used to be. And as with most agents, it's access that's one of the limiting factors presently. These are expensive medications. They're given through intravenous in a lot of scenarios. And so there are parts of the world that may not have the access that they need. And so there are efforts looking at ways to promote access, but it's an age-old issue. And it's going to be a similar issue with MOGAD. And hopefully we're able to get access to these drugs because we've completely changed the diagnosis of NMOSD. And a lot of us very infrequently now have to reach for emergency breakthrough treatment, which when you break through an NMO, it can be devastating. So these changes in NMOSD are really a paradigm shift.